Hello and welcome to the Clinical Liver Diseases video series. CLD is the official digital learning publication of the AASLD. I am Rahima Bhanji, Assistant Professor of Medicine and Transplant Hepatologist at the University of Alberta in Edmonton, Canada. I am also one of the co-authors of the paper Nonalcoholic Steatohepatitis, Sarcopenia, and Liver Transplantation. I would like to take a few minutes to highlight key points from our paper. First, I would like to discuss the common mediators between Nash and Sarcopenia. There are numerous mediators linking Nash to Sarcopenia. Some of the common mediators include insulin resistance, which leads to lipolysis and increased circulation of free fatty acids, which when taken up by the liver leads to hepatic steatosis, and when taken up by the muscle leads to myosteatosis. Insulin resistance also promotes protein breakdown, leading to sarcopenia. And once sarcopenia ensues, there is worsening insulin resistance as there is less muscle available for insulin-mediated glucose disposal. Another mediator is chronic inflammation. In the liver, as a result of beta oxidation and generation of free radicals, there is promotion of liver injury and fibrosis. These same cytokines in inflammatory milieu promotes further protein breakdown. Vitamin D works by promoting both insulin resistance and chronic inflammation. Vitamin D is responsible for regulation of insulin receptors, not only on the pancreatic beta cells, but also peripheral tissues, including the liver. So when there is vitamin D deficiency, there is promotion of insulin resistance. Vitamin D plays a key role in oxidative stress and cytokine generation. So when there is deficiency, there is promotion of chronic inflammation. In our paper, in Figure 2, we provide an illustration showing common mediators linking Nash and Sarcopenia. Second, I would like to discuss how sarcopenia impacts Nash and vice versa. Due to these common mediators, individuals who have sarcopenia have a fourfold increased risk of NAFLD. More importantly, they have a twofold increased risk of fibrosis and NASH. Individuals who have NASH have a sixfold increased risk of getting sarcopenic obesity. It is important to note that both conditions are synergistic, and presence of both conditions leads to worse outcomes. These patients have increased insulin resistance, more components in metabolic syndrome, and worse outcomes both pre and post liver transplantation. Finally, I would like to end by discussing the mainstay of treatment. We all know liver transplantation is the definitive treatment for individuals with end-stage liver disease from NASH. The cornerstone of management in patients with NASH is diet and exercise, with a goal of 7 to 10% body weight loss. This is the same management used for patients in sarcopenia. However, clinicians need to be cautious about a couple of points. First, we need to ensure patients have adequate protein intake, minimum 1.3 gram per kilogram per day. Second, we need to make sure patients combine caloric restriction with exercise. Studies have shown caloric restriction alone leads to loss of fatty tissue, but also up to 25% loss of fat-free mass. Combining exercise with the caloric restriction reduces loss of fat-free mass to 11%. Exercise promotes increase in muscle mass and also promotes increased insulin sensitivity. There are studies showing individuals who have improvement in muscle mass have a 20% reduction in development of NAFLD. For those who already have NAFLD, increased muscle mass increases chance of resolution by over 2-fold. On behalf of CLD team, I hope you've enjoyed this video. For more information on non-alcoholic steatohepatitis, sarcopenia, and liver transplantation, please visit www.cldlearning.com. Thank you for watching.